breast cancer, though it was not greatly increased. But if you look back, the number of women in whom breast cancer was diagnosed was definitely more than what was expected. Next slide. Right. So when we are managing menopause, we also have to keep in mind about risk of cancer, because we know that it increases with age. Also about screening and early detection. That is something which is actually a boon, because we can predict or we can diagnose conditions much earlier and then offer them proper treatment in order to uh, cure the cancer at the right time. And of course, there is a lot more knowledge about cancers available than what it was earlier. Next slide. Right. So uh, this is one picture which talks about various cancers in women, and the incidence and mortality of breast cancer increases with age and predominantly in the postmenopausal phase. So it is noted that a peak incidence is seen at around 65 years of age. Dr. Pranjali will, of course, will guide us on this. Next slide. And breast cancer is something which now, even in our country, is the number one cancer. We always talked about cervical cancer being the most common, but now in 2022, we know that breast cancer is more common than the cervical cancer, and it is the second most commonly diagnosed cancer all over. The incidence is rising in our country. It's almost 22.9%, which is definitely very, very high. Next slide. So, having talked about menopause in general, having talked about what are the therapeutic options for menopause and the concerns in our mind as a general gynecologist, time has now come to understand more about imaging of the breast, about preventing breast cancer, and we'll of course have some discussion about MHT and breast cancer. So now I invite Dr. Pranjali Gadgil to take over from this, and we are eager to listen to you, Pranjali.
Thank you. Thank you. So I congratulate the Lupin team for truly making this a multidisciplinary discussion, because the care of menopause is truly multidisciplinary. So we can't do this in isolation. I know that Dr. Biniwale and his team and a lot of other gynecologists are very good about involving us whenever they are starting MHT, whenever women are you have noted to have some issues on their mammograms or on clinical exams, to first get them sort of cleared by us to start hormone replacement therapy. And I wish I had an easy tool to classify women as, okay, this woman is at low risk of breast cancer, so go ahead. Unfortunately, we don't have that, because we do know that a lot of times women simply have no risk factors but still can develop breast cancer. So we have to exercise caution with every single case. The woman who doesn't have family history, women who don't have any prior history of breast abnormalities or biopsies, who are following a healthy lifestyle, we know they can still develop breast cancer. So it's important to pay close heed to breast health in the context of hormone replacement therapy. So I'm going to share my talk here. Let's see. So Dr. Biniwale has covered the initial part, and I'm going to focus on the breast as it changes at menopause. So we know that the gland starts to involute and breast density decreases, which for me, as you know, if I were looking at with my lens alone, it's great because breast density increases, it's easy to screen breast, proliferative changes like fibroadenomas start to regress at menopause. So I can't look at menopause from, my lens alone, but truly these changes are helpful in screening for breast cancer. And menopause per se does not increase breast cancer risk. This is an important point to remember, because the hormonal influence on the breast as it mitigates, and women who actually go through breast menopause earlier have lower risk of breast cancer compared to women who have a late menopause. However, these changes in the breast are occurring simultaneously with changes of aging. So the breast, as women age, will have loss of elasticity, sagging. Women do come to see us for cosmetic procedures, for breast lifts and things like that. But on the mammographic side, we start seeing vascular calcifications, atherosclerotic changes, thinning of the skin. And with age, breast cancer risk increases. So it's hard to quantify what is happening at each time, because both these changes of age and menopause are occurring in parallel. Now, when it comes to screening, we don't have to wait for menopause. Screening should start in the context of Indian women at the age of 40. So Dr. Biniwale discussed that, peak age of breast cancer worldwide is, or especially in Western countries, around 60s. In our country, it's actually 48 to 52 is the peak age of incidence of breast cancer. So if you start screening at 50, you've kind of missed the boat for a lot of women. It is still an individualized decision making in women who are high risk. Let's say, the mother had a breast cancer at the age of 35. That woman actually needs to be plugged into a high risk screening program, needs to undergo genetic counseling. We need to evaluate and give an opportunity for genetic testing to her mother first. And that becomes an opportunity for individualized risk assessment. So I usually tell women and their doctors that at 40, get your baseline screening mammogram. If a woman has high risk factors, refer her earlier for high risk screening strategy formation. And that is an individualized thing for each woman. But at 40, when you send her for your first screening mammogram, get her a clean baseline result. Now, we see this in India a lot, that, women go for their first mammogram. Then they're called back for an ultrasound. They see a lot of changes like prior existing, cysts, fibroadenomas. We don't know what growths are new, what growths are old. Somebody maybe advise a cyst aspiration. Somebody goes ahead for a biopsy. And by the time the woman has a first mammogram, she's so frustrated with the experience that she never goes back again. So we often know of women who we ask, have you done screening mammography before? Because now you've come to me with a palpable lump, you've got a breast cancer, which is stage 2, stage 3. Have you been doing mammograms? And the most common answer is yes, I got it once. That was 5 years ago. Everything was fine. Then I didn't do anything again. That beats the purpose. That is not why we do screening mammography. So when we start screening, the very first thing we need to do is educate women about why we're doing it. We're going for a mammogram when you don't have a problem. And that is the whole point of screening, because the ideal breast cancer to treat is when a woman can't feel a lump, neither can her doctor find a lump. And when you find breast cancer in that age, it's very likely you're going to find in situ cancers, stage 1 cancers, which are going to most likely over 90% have a complete chance of cure. And treatments are going to be less invasive, so lesser extent of surgery, lesser likelihood of needing chemotherapy, lesser likely of having nodal burden and radiation and all of these issues. So that is why we screen. Now, the technique of screening mammography is important. Quality of screening mammography has improved dramatically over the last couple of years. Worldwide, analog old mammos are being replaced by full field digital mammography, which has much better resolution, especially in dense breasts. We are combining that with tomosynthesis on a routine basis, especially for our women who are in the 40 to 50 age group and the breast tissue is dense. It offers a lot better resolution. You're getting multiple sections. The dose of radiation is low. Women often are really baffled when I say that if you had started screening mammography at 40 and today you are 50 years old, you should have had 10 mammograms if you are actually doing it once a year. And they're like, oh my God, 10 mammograms, kitty radiation, so much radiation. And they overestimate the risk of radiation, because the risks, the benefits of mammography far outweigh any theoretical risk of radiation and radiation induced cancers, because the quantity of radiation you're getting from a mammogram is the equivalent of what you get from nature and background earth radiation for 7 weeks, whatever you're exposed to. That's the same radiation you're exposed to when you go for your mammogram. So even practitioners sometimes are puzzled by questions on radiation, and then they will refer to sonography or ultrasound instead of mammography. And that leads to overdiagnosis of a lot of benign things and misses things like suspicious microcalcifications, DCIS, which we are actually looking for in a mammogram and is not going to get picked up by ultrasound. Now, to point out the differences in technique, if you look at the picture on the left, this is actually a friend of mine who at 1 year underwent a screening mammogram in an analog system. And the next year on the right, she underwent screening with a digital system. And you see with what I've highlighted in red is actually a small benign lesion, but you can't even see it on her previous mammogram simply because the technique is better. Your resolution is a lot better. You're seeing a lot smaller details. And it's not like her breast density has changed dramatically in 1 year. It's the quality of imaging that has gone up. And so you start seeing new things which weren't there before, which are not necessarily new growths. They're just apparent for the first time because of the technique you've chosen. So stick with a good quality technique from the beginning. I would suggest women who have access to digital mammography, go for a digital and a full field digital mammo, not digitization of analog systems, which is what a lot of people in community are doing, because just like people acquire digital x-rays with CR systems, that is what they're calling digital mammo, and it's not the same thing. So if you're going for a mammo, it's worth investing in a good quality mammogram and repeating the same type of mammogram year to year, so that we are comparing apples to apples and not apples to oranges. Now, when a screening mammo is reported, there is a BIRAD score which is given to the report. And my advice to doctors is simply, if you find anything BIRADS 3 and up, don't hesitate to refer that patient. We can sort it out for you. Because what I notice is really the ones that need biopsy are BIRADS 4 and 5. But in the Indian context, BIRADS 3 is actually incorrectly overused. What I mean by that is BIRADS 3 should be used for, things like calcifications, things like asymmetric densities on mammography, where instead of waiting a whole year to bring that woman back, we'd ask that patient to come back in 6 months to keep a closer eye on things. So it should never be used for a palpable lump, because there you're doing a disservice to the woman. If you have a breast cancer and you wait 6 months, that is actually bad practice. It's malpractice. It's increasing, mortality of that woman simply because you incorrectly reported a cancer. And if you actually have a benign lesion, either you're swearing on somebody's life that this is benign and reassure her, make it BIRADS 2. And if you need help of a biopsy to determine that this is benign, do that now. Don't do that 6 months later. So BIRADS 3, I find, is very overused, where somebody is saying probably benign because that's a confused radiologist and not the true indication for reporting a mammogram as BIRADS 3. So I usually recommend that if you find BIRADS 3 and above, just refer and let us take a decision of whether to, have that woman repeat imaging in 6 months or reassure her or biopsy today. Now, the other scoring that's done in mammography is background breast density, where if you look at the picture on the left, it's an entirely fatty breast. So it's very easy to pick up a suspicious lesion. And if you look at the breast on the right, it's an extremely dense breast, which is a, mammographer's nightmare, because how do you find a cancer which is going to look white when the background itself is so white? So breast density affects screening. And that is the major topic that we're going to discuss today. But this is how it's classified. It's a subjective assessment. Whether I call somebody to have scattered fibroglandular density or heterogeneously dense breasts is a subjective assessment. But volumetrically, it kind of corresponds to the category on the right is more than 75% of the breast is replaced by fibroglandular or fibrous dense tissue. Whereas on the left, less than 10% of the breast is actually fibrous, and it's very easy to screen in that breast. But it's a double-edged sword. It's not just about impact on mammography screening and hiding cancers and masking cancers. That's the issue with density. Breast density, as a function of having more active fibroglandular tissue, is associated with increase in breast cancer risk. And this came to attention about, a decade or two ago, where there was a lot of hype about breast density, and a lot of people didn't agree with what was being discussed. that whether it's an independent risk factor or not. But now it is, in most states in the US, it is law that with your mammogram, you should report the woman's breast density and caution her that mammography may actually not pick up your breast cancer in the context of very dense breast, because a woman may be falsely reassured if she's got dense breasts and has a negative mammogram. So this is actually mandatory to report, because if you don't report the woman had dense breasts and don't caution the woman about the limitations of mammography, and the following 6 months later she develops a palpable lesion, she actually is in her rights to come back and sue you. So we're a long way off from there in India, but we have to acknowledge that breast density increases a woman's risk and can mask cancers. And how does it correlate? Dr. Laszlo Tabar is a Swedish mammographer, and Sweden has been doing mammography as one of the first countries that implemented it in a systematic way. A large number of initial mammography trials were done in Sweden, and he does a lot of large section histology, where instead of taking bits and pieces and looking at them under the microscope, he grosses whole large sections and mounts those thick sections under a microscope to look at how things look at in large section. And if you look at these comparative images, they are really beautiful as to correlating what is happening in areas of dense breast tissue. So if you look at this first image, this correlates with a large number of TDLUs here packed in the dense tissue. If you look at the second image, if you look at these areas of lucency, they correspond to these fatty globules seen here. And these are Cooper's ligaments in between that we are seeing. And this is not very dense glandular tissue, but it's dense fibrous tissue. So density itself, it refers to fibrous tissue as well as glandular tissue. And fat, when it comes to fat, it's our friend when it comes to looking for cancers in screening. Now, when we talk about breast density, the risk of women who have these very heterogeneously and intensely dense breasts have almost a 2 to 6%, 2 to 6-fold increase in risk of breast cancer. And this is the third most largest contributor of breast cancer risk after BRCA status, which is your BRCA1 and 2 deleterious gene mutations. They by far are the most predominant risk factor, in the sense they impact your breast cancer risk more than any other factor when it comes to your likelihood of developing breast cancer. So after BRCA status is age, and the third is breast density, and it may account for almost 16% of all breast cancers. And at menopause, we know that density actually decreases. The other factors that impact are age. Age also, with age, breast density decreases. Higher parity lowers breast density. There is a hereditary component to it. So women whose mothers have dense breasts are more likely to have dense breasts. Alcohol is shown to independently be associated with increased breast density. Exercise, although it has a lot of benefits in breast cancer risk reduction, it does not, with conclusive effect, impact breast density. Now, how can we reduce breast density if density is, affecting us? We don't treat breast density per se, because, it's an asymptomatic issue. But we do prescribe tamoxifen to women who have an increased risk of breast cancer in special settings, especially BRCA mutation carriers, in women who have had proliferative changes like lobular carcinoma in situ, extensive atypia in the breast, strong family history without known genetic factors. And so in these women, when we do prescribe tamoxifen, which as we know is a SERM and estrogen receptor blocker, we do find that breast density decreases in at least 40 to 50% of women over 10%. And when you achieve a more than 10% reduction in density, your breast cancer risk decreases by 60% of whatever your risk is. So this is important because, even in women who we place on tamoxifen after breast cancer treatment in the adjuvant setting, when after a BCS, we are looking at their surveillance mammos and we see that, by putting on tamoxifen, now their breast density has reduced, it gives us a very reassuring feeling because we know that our hormone manipulation is working and that is going to decrease that woman's risk of at least local recurrence, independent of systemic recurrence. So women whose density decreases with aromatase inhibitor and tamoxifen use actually do better than women whose density is not impacted, because we know at the tissue level that drug is working. When it comes to HRT, we are looking at the opposite. So we do know that, as Dr. Parag Beniwale mentioned, that combined estrogen progesterone therapy does increase risk of breast cancer. Simultaneously, what is happening is that is associated with an increase in mammographic density. Similar to how the impact of estrogen therapy alone in breast cancer risk is not clear or it's minimal, we don't see the similar correlation on breast density in women who are being treated with estrogen therapy alone. Obviously, this is given only in women who are post-hysterectomy, but estrogen therapy alone does not impact breast density. And what we do know is if a woman between her screening mammograms is placed on HRT, there is a higher likelihood that her subsequent mammogram will show a slight increase in density. And we know it's a reversible change. So impact on density is also reversible. So if you've used HRT for 2-3 years, and then after that you've discontinued it for 5 years, your risk of both the breast cancer also decreases, and your actual breast density as measured on mammography is also going to be lowered. Even with 1 single year of stopping, actually, the density impact is seen. Same thing that we just discussed, we believe that there is not a significant risk of increased breast cancer if HRT use is less than 1 year in the average risk women. And we do know that this risk is also reversible with stopping. So once you stop HRT, your increased risk is going to be lowered again. The type of progestin is also going to make a difference, with certain progesterones affected with higher degree of risk compared to others. Now, when it comes to screening, we know that mammography can mask cancers, but the sensitivity decreases dramatically. So if you think you're 90% confident that the woman doesn't have breast cancer after a screening mammogram in a woman with no breast density, the women with high breast density, that sensitivity is only 60%, 67%. So that's a significant impact on reliability of mammography. So what happens is you can get interval cancers. You can give a report of a normal mammogram and the woman can come to you with a palpable breast cancer 6 months later. That is something called as interval cancer. And that's common in women, more common in women who have high mammographic density. There's also an increased recall rate, which means women get called back after undergoing a mammogram to undergo additional views, there may be mammography views like magnification, compression views we do. We may use supplemental imaging like add breast ultrasound, or if tomosynthesis was not done, we may add that. And in specific case scenarios, we may supplement that with breast MRI, especially in women who are genetic mutation carriers. But this recall rate is associated with a higher level of anxiety because, if you get a call back after a mammogram that, hey, we need to look at something in a little bit more detail, a woman, gets really freaked out and it increases anxiety dramatically if you recall a woman after a screening mammo. Even if that means after 2-3 additional images, her reports are normal, she's less likely to come back for the next imaging. And how this masking occurs at a histological, these are again Dr. Tabar's sections. And you can see how this cancer is hiding in this dense breast tissue. And on mammography, you're going to miss this in the background of white. Similar situation here. This is an example cited by Dr. Aparna Atre with star imaging. A woman with a strong family history. This is a conventional mammogram done after screening. You can't really tell, right? In this density, is there something here? Is there something here? Could there be something here? Could there be something here? Very hard to decipher with mammography alone. In our routine practices, these women are often screened with an ultrasound to look at this breast density to make sure we're not missing something in the dense breast area. But another tool that we now use is tomosynthesis, and this gets multiple views of the breast, much like a CT scan runs multiple slices. Tomosynthesis delivers low dose radiation in multiple slices and then synthesizes these images to form like a 3D image. So you can see this spiculated lesion arising here on tomosynthesis, which you did not see on your previous mammography slide. And you look at these things and you're like, oh, this is so subtle. But that's the point of doing screening mammography, to find things when they're not apparent to the palpable hand and not actually going to be life threatening. So tomosynthesis is a great tool in dense breasts. So when women are screening between the age of 40 to 50, I do recommend that they use digital mammography. And if you have access to tomosynthesis, by all means, go for it, because you're going to get a much better quality imaging. Breast MRI is another adjunct in very dense breasts, women who have a strong family history, women who are BRCA mutation carriers. What are you going to see in this dense breast? This again is a woman who is asymptomatic, can't see much on her mammo, but on your MRI, this is again Dr. Atre's case, that she's picked up a large lesion which is non-mass enhancement, and this corresponded to a large area of ductal carcinoma in situ. So these additional imaging techniques need to be used in consultation with a breast surgeon, breast disease specialist, breast radiologist, to see what is appropriate in what setting to pick up cancers we may be missing on conventional mammography in women who have dense breasts. But we certainly have the tools today. Now, in the context of Indian women, we know that overall they actually have a lower risk of breast cancer compared to their Western counterparts, which is great. Maybe attributed to our genetics, maybe attributed to our diet. But the peak age of incidence is lower. So if it's 48 to 52, you're going to see a lot more young breast cancers. We also see breast cancer in the 30s. So it's not, not every woman who is 35 and has a breast lump has a fibroadenoma. She could have a breast cancer, and she needs to be investigated from a diagnostic perspective very thoroughly. We know there are pregnancy-associated breast cancers, young breast cancers. We've diagnosed and treated breast cancer as early as in the 20s. So, but the peak age is 48 to 52, and that's a decade earlier than the number of 60s, which is mentioned in Western population. We see a higher proportion of ER negative, high-grade disease. We do see advanced stage of presentation, and that's purely because we are not a screening population. We are not a very breast-aware society of women. There are a lot of barriers to seeking attention, even for the palpable breast mass. And so women get diagnosed at later stages. There is often incomplete treatments because either, because of financial constraints, or simply because of wanting to try alternative therapies for the longest time before they actually come and see a practitioner of modern medicine. And so we have a much higher mortality from breast cancer compared to Western population. So in India, we have a much larger proportion of women we lose to breast cancer, although, even in absolute numbers, we lose a lot of more women to breast cancer, although the absolute number of cases we diagnose are lesser than countries like the US. Now, the screening scenario in India, as we know, is we're not a population screening population at all. We're not a population screening country at all. What we do is something called as opportunistic screening, where a woman who has access in a healthcare package goes for a mammogram. Oftentimes, there's a tie-up with a particular center where the mammography may not even be done as it should. So there is often poorly calibrated systems. They're old analog systems. When breast tissue is labeled as, oh, it's dense, it may not even be dense. It's just a bad quality mammogram. Ultrasound gets overused as a substitute of mammography. And there's an overdiagnosis of benign lesions, which cause a lot of anxiety, like I mentioned before. And once you diagnose things like, okay, you have a suspicious calcification. Now what? If the ultrasound doesn't show a mass, then what? The woman needs to be plugged into correct pathways of diagnostics once screening is done. And that is often missing when it comes to this fragmented healthcare package screening that is being done in corners across. So I've had patients who've had very frank suspicious calcifications, who was told that, oh, you see calcifications, come back for an ultrasound. She goes and undergoes an ultrasound. There's no mass. And the woman is told that, oh, there's no mass. Go back and, we'll see you back in 6 months. And by that time, she has developed a mass. But that's not the point, because you've missed 6 months of, an opportunity to actually diagnose her when it was still an in situ cancer. So any woman who does have BIRADS 3 and up does need to be plugged in with a center that is capable of doing advanced diagnostics if you're going to be screening. And this is the example that I cited. The woman on the left, underwent an analog mammo, and I'm like, I can't tell anything. Just go back and do a proper digital mammo, and then I can actually see something. So this is not dense breast tissue. The picture on the left, I mean, she does have heterogeneously dense breast, but this is not as bad as the picture on the left would have you believe. And that's simply poor quality mammography. That's not the density issue we're talking about. So we do need to pick better centers of doing mammography. What about breast density? Is it actually different in Indian context? And the very few studies people who've actually looked at this issue. This was a study out of PGI Chandigarh, and what they found is in screening mammograms that they did, breast density in women is actually lower than their Western counterparts, and that is what has been shown in Asian women across, even Malaysia and other Southeast Asian countries. So it varies. It varies between Asian women too. So, Chinese women have more dense breasts compared to, say, Malaysian women, and Malaysian women have more dense breasts compared to Indian women. So when we rely on data purely that says Asian breasts, it's not one and the same. As a risk factor for breast cancer, this was just a small case control study, again, done out of Delhi, and, breast density was, women were more likely to have breast density more than 50% in cases compared to controls with an odd ratio of 3.8. Now, so we do know that breast density is an important factor. We do know that HRT increases breast density. In parallel, it does increase risk of breast cancer, especially the progesterone and estrogen combined therapy. But we do have to acknowledge somewhere that, majority of patients who do develop breast cancer are not on any HRT. It's just something we have to take cognizance of when we are prescribing women HRT, that yes, let's get them plugged into a screening program. Let's assess how the HRT is going to affect breast density. We know that all our menopause practitioners do give the lowest possible dose for the shortest duration of time. It's essential. And I think more than being afraid of HRT, we have to find a way to work together so that I'm not the one just simply saying that, oh, HRT is bad. And, you're not the person saying, oh, don't worry about breast cancer. We all have to, talk to the patient in the same language. So it's great that we've done this discussion today. Moving to the topic of phytoestrogens, I'm actually going to hand the talk back to Dr. Parag Biniwale and have him discuss phytoestrogens a little bit more in detail. But when it comes to breast cancer specifically, one thing I will, the most commonly studied phytoestrogen source is soya. And I'm sure that's true everywhere. But if you start looking at data, it's just all over the place, because, initial studies when people discussed phytoestrogens were done on animals where large doses of isoflavonoids were given. Those animals did develop a in greater risk of breast cancer, but those were higher doses. And women in, humans don't metabolize soya the same way as animals do. Also, historically, when we used to think about, high soya diets, and is it going to affect tamoxifen efficacy in breast cancer patients? Again, that used to be a question, but now that's also been dispelled. The American Cancer Society does not express any dietary restrictions as far as breast cancer patients are concerned when it comes to soya and those related foods. But there is not enough data about supplements. So just because something is okay, it doesn't mean a large amount of it is great and fabulous. Because we don't recommend that, because soya may be protective now, let's package it in the form of isoflavone supplements and say that this is going to decrease your breast cancer risk, because we don't have that data yet. And on the flip side, we know that Asian populations like, Japan, who consume high quantities of soy, do have a lower breast cancer risk. The thought is that maybe isoflavones, inhibit action of more potent estrogen, and that's probably what's actually being protective. So the general recommendations are, we do not recommend for or against increasing or decreasing the amount of soya that women take in the context of breast cancer per se. If you love tofu, sure, keep taking it. But because you have breast cancer, don't start having, like 2 tabs of tofu, which you didn't have before. That doesn't actually make sense. But there may be benefits of having soya over animal protein. There may be benefits of having, soya associated with a vegetarian and high fiber diet in general. So the jury is still out on phytoestrogens when it comes to breast cancer. And here I'm going to stop my discussion, hand this back to Dr. Biniwale, and he is going to continue the discussion on the molecule we are here to discuss today.
Thank you, Pranjali. I think Dr. Reshma will do that. But before we hand over to Reshma, just a quick question to you. Now,
Yes.
we've always talked about the Gale model, which
Yes.
is used as a breast cancer risk assessment
Yes.
tool. What is
Yes.
your take on this? Because it has its own pluses and minuses.
So correct.
How reliable do you think it
So
would
we
be?
don't use the Gale model in the context of Indian breast cancer, Indian patients
Right.
in general, because this was a model that was studied in Caucasian patients. The Gale model, the Klaus model, there are newer models like BRCA Pro, Predict, is a whole bunch of models which have been studied in Caucasian women. And we do know that inherently, because those models, when they start calculating, they start your risk calculation at a 12% lifetime risk of breast cancer, which is way higher than what our Indian breast cancer risk is. In addition, we know that our age as a risk factor. If our peak age of incidence is 48 to 52, those models, are predicting the highest risk close to 60. So it's not just because of genetics, it's a whole multifactorial thing. So we don't use Gale models to predict an individualized cancer risk. What we usually do is rely heavily on, we sort of, when a woman comes to us and, we have them fill out a breast health questionnaire, one of the things we are able to look at very in detail is the family history aspect, because that doesn't change. Genetic risk is very absolute. If you are a BRCA mutation carrier, it doesn't matter whether you're Caucasian or you're Indian. Once you have a BRCA mutation, your lifetime risk of developing breast cancer is 60 to 80. So the genetic counseling, the patients who meet criteria of genetic counseling and testing, those should certainly not be missed. When it comes to other things, we'll focus on, modifiable risk factors. If their sheet says they don't exercise, we say start exercising. If we look at, have you been screening, they've not been screening, get them plugged into a mammography screening pathway. But you're right that we do not have, if I had this model, I could plug the patient in and give you a quantitative number that for this Indian woman, this is her quantifiable risk of breast cancer over the next 10 years. We simply do not have that model today, unfortunately.
Right. As you rightly brought out, because see, when we talk about Gale model, it takes into account the race, the age of menarche, age of first child, etc. But then there are certain factors which are not included in this. Is one is breastfeeding, which is again a very, very common thing as far as our country is concerned. Then second risk which is not captured here is the estrogen progesterone therapy. And again, let's be honest and say that not too many patients opt for the estrogen progesterone therapy. And of course, factors like BMI, alcohol, the physical activity, they are also not taken into consideration. So this is something which really is a limitation, I should say, as far as a screening tool or risk assessment tool is concerned. Reshma, over to you for the molecule.
Thank you, sir. Just I would need your presence and ma'am's presence, as we have received in fact, multiple questions on the topic. So I'll just recap. So there are multiple literature reports which suggested menopausal hormonal therapy is a mainstay, but definitive evidences of breast cancer has been linked to it. And as you mentioned, yes, the estrogen progesterone therapy together, estrogen alone. So there are multiple dilemmas which are run in and around this therapy. So can we change the perspective of MHD? Which may be a cause to the breast cancer. So yes, in order to reduce the burden of a breast cancer, a multidimensional approach and evidence-based strategic aiming at early detection and effective management should be implemented as fast as possible. A public health program that ensures access to the affordable diagnostic tests and treatments must be introduced. And an appropriate use of hormonal therapies with a proven safety, efficacy, and safety data has to be furnished and implemented soon. So now, is there any guideline which do support this? So can we select the alternative therapies over hormones, or can we mismatch them, or can we do them concomitantly? So yes, there is a Indian Menopausal Society presents and recommends the guideline which says that non-hormonal prescription agents may relieve vasomotor symptoms, but have their own side effect. These can be considered when MHT is absolutely contraindicated or not desired, and awareness should be created using phytoestrogens or any lycopene-rich food in Indian diet. Because Indian diet is most of the time enriched with many herbal formulations and as well as herbal preparation, which may people take orally as of what they prefer taking it. So is there any alternative to hormone therapy in managing menopause? There are multiple guidelines which says yes to that. So botanicals and phytoestrogens, what they say is the role of phytoestrogen has stimulated considerable interest in population with high use of isoflavone as suggested by Dr. Pranjali as well, such as the Japanese appear to have the lower rates of vasomotor symptoms, cardiovascular event, as well as osteoporosis and the incidences of breast, colon, and endometrial ovarian cancers. Clinicians should be aware of the range of options available and be able to discuss their advantages as well as the disadvantages and specific risk factors, balanced in the evidence-based manner and the with quality of life, which is totally dependent on these management therapies. They are also itself termed as a conditions. So it should be an open conversation. And now I'll quickly take you to the what we can say on this. The novel and clinically proven formula for menopause in collaboration with Finzelberg is being analyzed and practiced since 1950. It is registered in Germany in 1993 as one of the phytomedicine. And there are multiple evidences available right from the animal studies, research papers, which speak on the treatment of perimenopause and postmenopausal symptoms. In fact, in USA, it is approved in 2008 as a new dietary ingredient, which is notified in the FDA. So what it actually says, we have Eastroes in India launched. If we look at the timeline, it is in Germany since 1993, followed by USA in 2008, followed by South Africa in 2011 and Canada 2012. And in India, we have launched in 2019. There are multiple reports which are already existing, but it was of interest to study the same formula in Indian women. So what we found out, in fact, the study was conducted across India at 10 different centers, and it showcases 68% reduction in menopausal symptoms. And the same has been published in Journal of Midlife Health, which showcase that plethora of evidence, safety and efficacy in women with the menopausal symptom. So what I would say here, the transition is inevitable. We cannot skip that, but how we can make it more stronger and how we can ethically balance every woman's life is more of importance. The quality of life related to menopause speaks a lot about the disease, because we cannot say it's a disease, it's a physiological change in the body, which has to be accepted as it is. So let's do it together and let's stand together for all women. So, sir, ma'am, we have received a couple of questions. So shall we?
Sure.
Yeah. So we have received a first question from Dr. Sumaida. Can we provide MHT continuously for more than 3 years?
See, basically, MHT can be provided up to 5 years, though the dictum is it should be for a shortest duration of time with the smallest possible dose. But there are studies where MHT, especially, see, if you're dealing with a woman who's young and who lands up in premature ovarian insufficiency, So the recommendation is to continue giving her hormone therapy till the natural age of menopause. So if you have a woman who develops POI at the age of 35, we can prescribe her MHT till the age of say 46 or 47. But of course, having said that, it is important that she has to be under medical supervision. So a regular checkup, regular investigations, counseling, follow-up is something which is really important.
Okay. Thank you, sir. The second question, what we have received is, though you have shared the symptomatic and asymptomatic changes, but the question is, what symptoms indicate that now this is the start for MHT? Else we can manage with any other therapy.
Basically, MHT is not meant for asymptomatic women. In the 90s, there was a thought that we could prevent cardiovascular diseases, and we did offer MHT to women. So then it was found out that because the estrogen basically has a lipid lowering property. But then we found out that the statins are much better as a therapy for as lipid lowering agents rather than the MHT. So the use of MHT for such indication was not there. So for asymptomatic women, it is really difficult to select because it is not indicated. So unless the woman comes up with a symptom, and then you discuss the management options, and finally it is a joint decision to offer MHT to women.
Could you be able to guide either you or Pranjali ma'am, that is any particular dose of tamoxifen to reduce the breast density?
As I said before, we are not actually prescribing tamoxifen to reduce breast density at all. Because we are using tamoxifen to only decrease breast cancer risk in women who are high risk. So what something we call as chemoprophylaxis, which is, misunderstood because it's not actually chemo, it's just endocrine manipulation. And that too, we don't give it for a period of more than 5 years when we are prescribing it for prevention in high risk women. And in that, the dose is very much still 20 milligram per day, which is the same dose that has been studied in the P1 and other trials. Same dose that we use as adjuvant treatment for breast cancer. The only place we actually use 10 mg tamoxifen is in treating gynecomastia and sometimes in women who have very severe cases of mastalgia. But everywhere else, when we're trying to work on breast cancer risk, the dose study is always 20 milligram, but not to treat breast density.
And how to manage the typical vasomotor symptoms? MHT is the only option, or can we give them any other complementary or alternative therapy?
See, MHT probably is the best, but we always say that the first option is lifestyle modification, right? So diet is something which is important, and here you may add little more amount of phytoestrogens, like Pranjali has said, tofu, etc., in the diet. That is number one. Secondly, reduce caffeine, reduce alcohol, stop smoking or reduce smoking. Then changing the dressing pattern is also important because typically it is noted that women are more comfortable if they are wearing cotton clothes. So the possibility of hot flashes is supposed to be less. And then if with lifestyle modification, if there's no relief, then comes the therapeutic option where you can offer her either MHT or other medications. Now, we know that MHT is the best, but if the woman is not desirous of MHT, we can always switch over to other medications. I have personally used estrogens in quite a few patients who came to us with hot flashes and who did not want menopausal hormone therapy, and it worked very well in relieving symptoms.
The next question is, does obesity or high weight gain impacts or progresses toward breast cancer or any other type of cancer?
So yes, obesity is known to increase breast cancer risk. Weight gain after menopause is known to increase breast cancer risk. Weight gain, even pre-pubertal, or pubertal weight gain, is known to increase breast cancer risk later in context of postmenopausal breast cancer. So weight is an important factor. So management of BMI. Also in patients of breast cancer, weight gain after breast cancer treatment again is shown to increase risk of breast cancer relapse. And very understandably, right? We know that there is peripheral estrogen being generated even in postmenopausal women in adipose tissue, and the other metabolic changes that come with weight gain impact even the hormonal milieu and cause increased risk of breast cancer. So
The next question is the endometrial changes which are associated with menopause. When we should start detecting them, and any simpler diagnostic tools for the changes to detect?
Okay. First of all, endometrial changes are best detected on transvaginal ultrasound, right? And the cutoff of 4 millimeters is something which we all have to remember. So if you do a transvaginal ultrasound in a menopausal woman, and then if the thickness is less than 4, we can say that the risk is very, very less. If it is more than 4, we just have to keep a track, maybe repeat. If the patient is not symptomatic, we would repeat a transvaginal ultrasound after 3 months or so, right? But if any menopausal woman comes down with a history suggestive of spotting or bleeding, then a transvaginal ultrasound is a must. And then depending on the report, we decide what action to take further.
The next question, this is particularly to Dr. Parag only. When can we combine the two treatments? Can we do that? I mean, giving the phytoestrogen and then suddenly shifting to MHT and vice versa. Is it possible?
It is possible. I mean, it's not contraindicated, but then usually women prefer to take either or, right? So if there are women who are suffering from acute symptoms, then probably the estrogen or the hormone therapy is much better and it acts faster. But the other therapy can be used on a long-term basis, may not require as much monitoring, and it can be useful in some way.
How to select
But
the
I mean, there's no
phytoestrogen?
contraindication for using both the therapies. I have never used it. I have never given it to any of my patients. It's always either or.
The same doctor has asked how to select a phytoestrogen. Any particular guideline or a norm which says these are the pointers with which you can select a phytoestrogen?
There are no guidelines. The Indian Menopause Society nor the International Menopause Society have any guidelines on selecting a phytoestrogen. So whatever is available in the market, you just have to try it out and see which one works well.
Sir, I think this was the last question. And sir, can you summarize, you and ma'am can summarize some pointers which will help our young practitioners?
Right. First of all, menopause is something which should not be ignored. Somehow, I always say that menopause is not as glamorous as infertility and fetal medicine. So the gynecologists are not attracted to menopause, but we have to understand that in the years to come, the newer generation is probably going to see more and more women who come back to gynecologists with problems of menopause. So we must look at it rather seriously. There are so many advances which are there in the diagnostic. There are diagnostic tools that are available. There are so many therapeutic options that we have for management of menopause. And then we have specialists like Dr. Pranjali in our city who really are doing focused work. So, the menopause management definitely is the thing which we must watch out for in the next couple of decades, I should say.
Dr. Pranjali, could you be able to summarize 2-3 pointers which every woman also can just remember when she should go and check and what should she should opt for it?
Yeah. So one thing is, remove all reservations you may have about mammography. After 40, recommend it to all patients, all women, once a year. Because if you say every 2-3 years, they're going to do it once in 5 years and come to you with a palpable mass. So once a year mammogram after 40. When you're doing it, do a good quality digital mammography. Don't be afraid to refer. This is a very difficult area. There's not a whole lot of expertise in community radiologists because the eyes cannot see what the mind does not know. So simply if you have a query that, does this calcification look okay? Or is it something that needs attention? Just, we are here to help you out to make those decisions, whether in the context of HRT or not and menopause or not. Whenever you have a doubt, just get it checked out. So don't be afraid to refer patients simply to run by with a normal mammogram and see whether it's okay. When you are starting HRT, use the opportunity of menopausal symptoms. Like most commonly, women see their gynecologists around menopause for perimenopausal mastalgia. And that's a great, we usually have to reassure women that this is just, cyclical change, anovulatory cycles, increased gland density lasting and for a longer duration of time. And you probably don't need much done. But it's also a great opportunity to have the conversation about mammography. And don't start doing mammography without having this conversation that why are you doing it? Why is it important to do it once a year? It's important to follow changes over time. So keep your last year's mammogram at hand when you're going for this year's mammogram. If there is a change, it doesn't always mean it's cancer. Just, that it just means it needs a closer look. Resolve the first mammogram to a clean baseline, and only then will women continue to do annual mammography afterwards. So I think don't be afraid of breast density. We have plenty tools to overcome its limitations as far as screening is concerned. And as far as the increased risk of breast cancer is concerned, we have to acknowledge it and continue to screen. So that is the only message here.
So it was a wonderful session conducted today. Dr. Parag and Dr. Pranjali, it was immense pleasure to listen to both of you with respect to the statistics, the modalities, what we can do every time, and how a woman can improvise herself to achieve a better quality of life. That is also important. So this must have enlightened the young practitioners, the existing practitioners, as well as all the crowd across the Facebook link also, because this was open to the Facebook viewers as well. So thank you so much. And this digital platform, I should thank Imagika for this, making it more interactive and live session for all of us. Thank you so much. And thank you, Sandesh, for all the technical handles. Thank you.
Yeah,
Thank you, Reshma and the team.
Thank you.
Yeah.
Thank you. It was
Thank
great
you, madam,
participating.
Dr. Gargid, for such a wonderful session. And thank you so much.
Thank you. It was a
Thank
pleasure
you.
being here. Thanks for having me.
Yeah.
Thanks,
Bye-bye.
Dr. Biniwale. Bye-bye.
Bye-bye. Himanshu, you can stop the streaming.
Okay, ma'am.
Yeah.
Himanshu, it was told to you, na, ki you will be indicate